Talks live. Tonight I have with me Dr. Margaret Roubaud from MD Anderson Cancer Center in Houston, correct?
Correct.
Okay, so folks, we're going to give you a couple of minutes to jump on board this evening. I'm expecting a nice crowd. A lot of you said that you wanted to come and meet Dr. Roubaud. It's going to be a wonderful show. I've never done a show on osteosarcoma, so we're combining osteosarcoma and targeted muscle reinnervation. I'm really, really excited about this. For those of you watching the replay, y'all have been doing a wonderful job this past couple of weeks of leaving me comments in the section saying replay and putting in your questions there. Guys, I do go back and read the comments from the previous shows to answer your questions. So if you're watching the replay, go ahead and chime in and say replay. Hey, we got our first viewer there. There's Eric there from Tennessee watching me from the YouTube channel. So guys, I am live both on my Facebook channel and Cosi Talks YouTube channel. So that's my shameless plug for the YouTube channel right there. All right, guys, you know me. As you jump on board, I love to know who I'm talking to. So tell me who you are, where you're from, and what's in your coffee mug. Dr. Roubaud, I forgot to tell you, you had to bring a coffee mug this evening. That's my fault.
I always have a coffee mug.
You always have, I was like, yeah. You're in healthcare and you're a mom. You're going to have a coffee mug. That's for sure. All right. So we got Mark on board. Welcome. What's up, Mark? We got Jill with her water from Berkeley. We got Alberi. Gracias por venir, Alberis. And I've had some of my more Spanish-speaking audience on board lately, so I'm enjoying that. Tom, thank you so much for sending me the tire tread for the running blade. I just received it. I haven't sent you a thank you, so thank you, thank you, thank you. We've got Beth Hudson from New Hampshire. Nothing in your mug yet. Come on, Beth. Going with Sandra coming in, Floridian right there. We've got Donna from Ontario. We got a lot of Canadians on board this evening.
All right.
Cosi showing those guns. Mark, you crack me up. That's hilarious. So we've got Michelle. Oh, yes, Michelle, of course. And Joe, of course, I remember you and Joe. Michelle, thank you for coming this evening. This is going to be a special show. So, guys, we've already got a nice group growing here. We've got, my residential occupational therapist, Andrea, there on board. Guys, thank you so much for coming and for all the support that you guys have given this past week. It's Pastor David. It's a party in the house. Okay, so for those of you who are watching the show for the very first time, welcome. My name is Cosi Belloso. I'm a physical therapist, amputee specialist here in Tampa, Florida. And with me this evening, I have Dr. Margaret Roubaud, my apologies, board certified plastic surgeon at MD Anderson Cancer Center. And I do want to take this time to thank my sponsor. They've been my sponsor this full year, but for this evening, TMR Nerve, targeted muscle reinnervation. Y'all have heard me talk a lot about that this year, and we're going to talk about it more tonight. So I'm going to go ahead and zip it for a moment and let Dr. Roubaud get a word in and tell us a little bit about herself.
Well, as you said, I'm down here in Houston, Texas. It's about as muggy as it probably is in Florida. I'm a plastic surgeon that came to do a fellowship at the Cancer Center about 7 years ago. And now I specialize in some of our oncologic amputees. And for about 3 years, I've been doing TMR at MD Anderson. We do it as a multidisciplinary practice, so in conjunction with our colleagues in ortho and anesthesia and PT.
Wonderful. And guys, I got to tell you, in our pre-interview, I had such a wonderful time talking to Dr. Roubaud, someone who is an amazing surgeon herself, but then also really utilizes the team approach in the healing part of her patients. And y'all know watching the show how much I feel about that. So let's see. Oh my, we've already got questions rolling in. So let's just talk about a little bit what y'all can expect tonight. So I've actually never done a show on osteosarcoma. And it's something that I've always wanted to do. And I've been kind of waiting for that just the right special guest to bring on board to talk about it. I am a cancer survivor myself, although it wasn't osteosarcoma. So I have a soft spot in my heart for fellow cancer survivors. And as we're going to learn tonight, cancer-related amputations actually only account for less than 2% of all amputees. So it's not a lot by the numbers. But for whatever reason, I have many of you who watch this show. And have been watching this show for quite some time. So for those of you who don't mind, if you are an osteosarcoma survivor, please feel free to put it out in the comment section. This evening is meant for you. And those of you who are not osteosarcoma survivors, there's a lot of wonderful information about targeted muscle reinnervation that will be applicable to you. All right, we're going to give a couple more shout outs and then we're going to get going. We got Diana on board from Riverview. We've got Barbara. We got Sharon, and she is from Omaha and a 25-year epithelioid sarcoma survivor. Bravo. Bravo. Let's see. Okay. Whew, there's Johnny V from Poughkeepsie, New York, in the Cosi Talks house. See, I told you we could expect Johnny V to come in and make an entrance right there. Let's see. Beth is a hip disarticulation cancer survivor for 42 years. Wow. Love, love, love hearing this. So, guys, we're going to go ahead and do giveaways this evening. Okay. And the reason why I'm saying this is because I want you to get your phones out right now and go to TMR Nerve on Instagram and follow them. We're going to keep that giveaway open through the show, and I will announce a winner at the end of the show. So y'all still have time to get in on that giveaway. So TMR-Nerve. And actually, Becca, if you wouldn't mind typing in the Instagram handle into the comment section so people can find it on Instagram and show my sponsor some love this evening. Okay, so let's talk a little bit about cancer-related amputations, right? So a lot of questions I get, Dr. Roubaud, from folks not in the healthcare. They say, does everybody who has cancer in their bone get an amputation? Okay, so no. And usually how we clarify it is if it's the primary. So if the primary cancer is bone cancer, that's where we might see the amputation. This does not apply to secondary bone cancers, meaning a cancer that started somewhere else in the body and then metastasized to the bones. Okay, so that's one of the first clarifications that I wanted to make. Dr. Roubaud, do you get a lot of questions about that from your patients?
Yeah, I think one of the main things to understand is that as physicians and surgeons, our goal number one is always limb salvage. So just because there's a tumor in the bone, whether it's a metastases or a primary, the first goal is limb salvage. And then secondly, if the bone gets to a point where either the metastasis has fractured enough times or there's issues, then we may consider it. But under no certain terms is our first goal to be amputating limbs for cancer.
Right. So let's talk a little bit about, some of this, just the basic statistics, right? So among amputations, all amputations, okay, approximately 54% are related to vascular incidents. So folks with complications from diabetes, vascular disease, right? And then trauma usually is some form of accident or, war-related accidents and trauma account for 45%. So as I mentioned in the beginning, less than 2% of our amputations are related to cancer, right?
Yeah.
So we're just going to cover, and I was saying, as I was doing some of the background research for this show, there's so many different cancers of the bone. So we're just going to kind of tackle the main three that many of you may have heard about, right? And we've got comments coming in left and right. So here, let me see if we can catch these. Michelle, Renee, yep, she's got a son, 16. He's now 18, Ewing sarcoma survivor. Johnny V is a synovial sarcoma survivor for 20 years, and he's a left BK. Let's see, Diana reached her 5-year survivor mark this month. Congratulations, Diana. Thank you guys for sharing all of this. Barbara says, I am a clear cell sarcoma survivor. Y'all are going to be the ones giving the talk on this show. That's what I'm thinking.
Usually.
I'm hearing some really specialized ones here. Okay, so guys, there's three main bone cancers that you will hear about. You're going to hear about osteosarcoma, which is what we've mentioned. You might hear about Ewing's sarcoma, which is what Joe recently battled right now. And then you might hear about the chondrosarcomas. Okay, so let me see if I get this right, Dr. Roubaud. The osteosarcoma is the most common one.
Yes.
Okay, and it's the most common one, and it usually occurs in our younger population from about 10 to 30 years of age. Very rarely in our older population. Yes?
Correct. Yes.
Okay. And then we have Ewing sarcoma, which is the second most common bone cancer in the pediatric and the children population. Yes. And then we have the chondrosarcoma, and that's the one that is more common in our adult population.
Yeah, it can be. And they all, we can talk through it, but they all have sort of a different pathophysiology, how they manifest and how they behave as well. They're all very different.
Okay, so tell us a little bit, for example, the difference between an osteosarcoma and a chondrosarcoma.
Well, the osteosarcomas are usually coming from what we call the osteoblasts, or the osteoclastic cells of the bone marrow. And they have a different behavior. They will respond, if we're lucky, a lot of times to chemo. So a tumor that starts large if we can get someone on chemo early, we may be able to shrink the tumor down before surgery and offer limb salvage. Chondrosarcoma is not a very nice player. Chondrosarcoma comes more from the chondroblasts, which are more commonly linked with the cartilage around bones. Chondrosarcoma doesn't really respond to much but surgery. So surgery is our front line if it's a chondrosarcoma. And then Ewing's, which is good for kids, is generally responsive to all three treatments. So chemo, radiation, and surgery. So it's sort of, you know, the one that we throw the kitchen sink at.
Got it. Okay. And then as far as general risk factors, because this is one of those things people are just like, well, am I, you know, how do I know if this might happen to me or my child? Tell us a little bit about some of those general risk factors for folks.
Yeah, you know, honestly, this is not one of those cancers that is super preventable. I mean, everyone should eat right, live right, try to do the right thing. Unfortunately, bony cancers tend to be more on a mutation in the germline or in a genetic. There's certain syndromes associated with it. One is a Li-Fraumeni. There's others associated with it. And so it's generally something we see either by just bad luck, just truly bad luck, or two, associated with a syndrome.
Now, as far as and then the other one is, so which one is the one, and you'll have to remind me on this one, sometimes the children who receive certain radiation protocols are at a higher risk for a cancer later on in their life. Is that typically what you would see with?
So you'll see that more with like angiosarcoma or radiation-associated sarcoma. It's super rare, and it is generally thought from old radiation protocols that our radiation's gotten a lot better, but it can happen.
Okay. And guys, I'm going to go ahead and announce we had an email subscription contest prior to the show. So let me just give a little bit of a plug here. TMR Nerve has a wonderful website. I really, really, really love their website. It is full of so much good information. They have, my favorite part is they have a physician directory. So by state, you can look up physicians that perform targeted muscle reinnervation. And many of you have told me that you have found your surgeons this way. They also have a wonderful blog. I'm not one to sign up for a whole lot of email subscriptions, but this one's a good one. So we had a contest, and it was Johnny V is our email winner. So Johnny, you're going to be receiving a very nice Yeti mug, and I'm enjoying my drink here this evening. So congratulations, Johnny. We'll be reaching out to get your address to send you your prize. Let's see. Barbara is asking, Dr. Roubaud, have you treated many clear cell sarcoma patients?
I've treated probably a little bit of everything. We're sort of a sarcoma center of excellence at MD Anderson. So whether it is a bony sarcoma or a soft tissue sarcoma or one of those kind of bucket list sarcomas that goes into a not otherwise identified, Dr. Valerie Lewis and her team and the orthopedic team and the medical oncology team are world-renowned experts. And so I've treated them as part of her treatment team.
Wonderful. And yeah, a little bit later on, we're going to talk about the patients that Dr. Roubaud has seen. She has literally treated every level of amputation, literally. So let's talk a little bit about the symptoms, you know, and this is something that I'm going to put my little physical therapy plug into here, and we're going to talk about that in a minute. So what are some of the symptoms that might indicate a necessary workup for an osteosarcoma?
I mean, generally, the hardest part is they're vague. I mean, generally in kids, they'll start just complaining that their ankle hurts or their leg hurts, or they'll be on the sports field and they'll fall and they're just not recovering from an injury. So it's usually bony skeletal pain, which is why a lot of times we don't catch it until somebody goes into their primary care doctor and they order imaging or an x-ray. Now, obviously, if it swells or pushes out on things, it'll cause pain faster. But you know, I have patients that they fell off a horse and they thought, I fell off a horse, that's why I hurt. And then 6 months later, it still hurt. So, you know, it's kind of really vague bony pain.
Okay. And oftentimes, guys, a lot of times you've been seeing me promote my profession a lot lately on social media and the whys behind a physical therapist. I myself, you know, when people are in physical therapy and they're presenting with pain, right? As physical therapists, we are trained to try to figure out a differential diagnosis, meaning where is this pain coming from? Is it truly coming from orthopedic pain, musculoskeletal pain, and something that we can fix, or is there a deeper problem? And this is one of those things that we learn to try to differentiate, is if this is a pain that is not improving with treatment.
Yeah, I think that if your pain is not improving with treatment, or it's, yeah.
Yeah. And also the same thing with recurrences. So for my clinicians out there who are listening, I know many of us have stories of having patients who have a history of pediatric cancer or any other kind of cancer. And during the course of treatment, we inadvertently, find that they have evidence of a metastases, a bony metastases. Actually, we all know the Olivia Newton-John, who recently passed away, and obviously hers was breast cancer. But she knew she had a recurrence because she was in physical therapy and the pain in her sacrum was not improving. So that's my little shameless plug for my profession right there. But it is one of those things where communication, folks, with your physical therapist and with all your clinicians can just kind of help turn on a light bulb in some cases. So let's see. Susan says, my TMR operation was done by a plastic surgeon, and 7 years after my amputation, it was just 5 months ago today. Wow. Wonderful. And we're going to be talking a lot more about TMR in just a little bit right here, guys. Okay, so let's talk. So the diagnosis itself, right? If there's some sort of suspicion, usually it's the classic imaging. So between X-rays, MRIs, eventually leading to a biopsy, and that's basically that's going to tell you right away what's going on right there with the biopsy. So when they're looking at this bone, this cancer, and they've determined there's cancer there, they're looking to see about the stages of the cancer. They're looking to see about how aggressive this cancer is. So tell us a little bit about those beginning stages with early diagnosis.
Yeah, so a lot of it's what the tumor itself is doing. So how big is it? Where is it? Has it broken through a cortex of the bone? Has it invaded the soft tissues around it? And so one is just the tumor itself. What we'll also add to someone's stage is that in general, they'll recommend some scans to examine the rest of the body and check the lungs or check other places where bony mets will frequently go. It's usually the lungs. And if those are negative, that puts them in a much lower stage because it means that those nasty cancer cells haven't escaped the leg or the arm. They haven't made their way out yet. So it's all about how the local tumor is acting and then has it gotten out and gone anywhere.
Okay. And then tell us about the treatments. We briefly touched upon, which cancers respond best to which kind of treatment. But basically, we have the options of radiation, chemotherapy, and surgery, right? Those are the three big ones we got. So if you want to tell us a little bit about those three options again.
Yeah, so the whole idea of treating with chemo or radiation, if you can, prior to surgery, is to shrink the tumor, to contain the tumor, let you get a better margin, or to get the tumor out before you really have to compromise important structures like vessels or nerves. And so if it's a chemo-responsive tumor, you'll get what they call neoadjuvant or pre-op chemo. And you may need some after, but that's the rationale. It's one of the ways we've moved into more limb salvage and less amputations is chemo. Radiation, on the same token, is a way to stop the tumor metabolism and kind of freeze it and try to contain it and get better margins. And so both chemo and radiation, if the tumor is sensitive to them, can give you a much better chance at limb salvage, or if you have to have an amputation, to lower sort of the level. For tumors that aren't responsive, though, to either of those modalities, you just have to go straight to surgery. And you try to get the tumor out before it can metastasize or push on any other structures.
And even when you're going in for the surgery, the goal is not the first line of defense is not automatically an amputation. Many times it's exactly that, to try to excise the tumor with clean margins, and then determine if it's enough to have a sound limb.
Yeah, what we do, we can tell a lot of times before even getting into the operating field, because there's what we call multidisciplinary conferences where the orthopedic surgeon, the medical oncologist, the radiation doc, and me will look at them and say, do you think this is possible? And so we have a general idea, but before anyone ever leaves the operating room, you get negative margins. And at that point, if it's possible to do a limb salvage, of course, that's what we're going to try to do. That being said, sometimes it just doesn't work out. So.
That's right. Now, there's a couple of other options, and I always like kind of mentioning these because I just find them to be interesting procedures themselves. Tell us a little bit about rotational plasties. And by the way, guys, thank you for putting in your comments. I would love to hear from my survivors right now. What was the course of your treatment? Did you have radiation? Did you have chemo? Did you have amputation right away, or was it a delayed amputation? So start putting those comments in there for me. But tell us a little bit about rotational plasty.
Rotational plasties are a really specific and interesting surgery. It's a way to basically create a neo joint where there wasn't one. And for lack of a better way to describe it, the lower leg is put on backwards at the knee joint. Now the foot and the lower leg are never completely removed from the leg itself. It's turned 180 degrees. And the foot then becomes the base of the knee joint. And it's really popular for usually more pediatric patients that are highly adaptable and can do a lot of physical therapy. But shameless plug for your profession, I would say the hardest part of that surgery is actually the rehab. You have to really retrain the body.
It was actually one of those first pediatric surgeries that I saw when I was working at the Shriners Hospital right here nearby. And I was a high school student, and I remember seeing the child and I was going, what happened here? And it was just fascinating that we could do that and make the child functional. So let's see. Johnny says, my tumor was growing in my foot and could not be properly diagnosed for imaging until it was observed growing into my arch, which took some time with correct diagnosis. And his was an immediate. I remember him telling me he left below knee amputation was the only treatment. Let's see. Willard says, I had chemo for 2 years and limb salvage, and I ended up getting amputated above the knee when I was 28 years old. Let's see. Thomas says, my old hanger RVP has rotational plasty. Let's see. Susan says, yep, I've seen that online with the rotation plasty with the foot at the knee. Let's see. What is Barbara? I had an amputation 10 years ago. Barbara, you didn't finish your comment. Finish your comment. I want to hear what you have to say. Let's see. Tom says, I was brought to be a peer visitor a few years ago for a 50-year-old gentleman who was diagnosed with cancer in his left foot before he decided to have his amputation, and that was quite the journey with him. Let's see, Sharon is epithelioid sarcoma on top of the foot, had a right BK followed by the chemo. So Barbara said there was no treatment for the clear cell in her case, it sounded like. Okay. So, and then can you touch upon our upper extremity? I don't get to cover very much with my upper extremity amputees, and I always love to throw them a little love there. So tell us a little bit about your experience with osteosarcomas for the upper extremity.
Well, if you have osteosarcoma or a similar tumor in, for example, the humerus, which is the arm bone, or some areas, you can definitely attempt limb salvage by either doing bony transplants or different soft tissue flaps to try to save the arm. But unfortunately, some of those tumors will get close enough to the shoulder girdle. And basically what happens is they start infiltrating into the shoulder girdle and basically the blood vessels and nerves under your axilla. And at that point, what happens is even if you were to get the tumor out, you would take out the blood supply and the nerves to the distal arm. And so we have different levels of amputation in the upper extremity, just like the lower. The lowest would be what we would call a partial hand. As you move up, it's called a transradial, transhumeral. And then one of the things I do that's unique is either 4/4 or extended 4/4. And it basically means that you disarticulate. You can do a shoulder disartic, but a 4/4 when you do the shoulder, you remove the arm, but you also remove the clavicle, your AC right here, your acromion, and then your scapula. So you lose the whole shoulder mechanism as part of the amputation. But what's really exciting about TMR in the upper extremity is some really smart surgeons before me figured out how to turn some of those into higher level prosthetics.
It's amazing. It's amazing. We're going to get a little bit more into details in just a few minutes, guys. So let's see. Beth says, I had pain for 2 hours with 2 ER visits and x-rays in the fall of second year. I felt the tumor while massaging my thigh, and it was the size of a squash ball and had eaten through the femur. So in her case, University of Chicago diagnosed it, and no other options available other than amputation. Ashley, there's my Tennessee girls, about ready. You came on board. Thank you for joining. Let's see. Willard says 37 survivor of osteosarcoma of the right tibia. Robin, she's a dear friend, limb salvage.
I'm sure she's coming back.
Osteosarcoma when she, am I here? Am I back? Am I back?
Yep, you're
Yeah.
back.
Okay. Okay. Let's see. Where did I leave off? Diana says she's a paracel osteosarcoma, several surgeries over 11 years before the amputation, also tried chemo and radiation before amputation as the cancer just kept recurring. And she is a right above the knee amputee. Johnny says having to decide on amputation for treatment was emotionally and one of the most difficult decisions I have ever had to make in my life.
Yeah, I mean, I think that one of the things that is very different in this amputee population is it actually is a choice. And we can talk about that a little bit more, but unlike a traumatic or sometimes a vascular amputee where, you know, it just has to be done to save your life, a cancer patient, it's a choice, and it's a hard one to make and a really emotional one.
Yep. So, you know, in our pre-interview, we talked a little bit about when you utilize the amputation actually as a form of pain relief for some of your oncology patients, and it's a tough thing to discuss, but I think it's something that cancer is a tough thing to discuss regardless. So, you know, so let's get into that part.
Well, as you've seen in the chat, a lot of people go through a lot of limb salvage procedures, and then some of them have their cancer come back. A lot of the treatment itself can cause pain. So if you give a lot of chemotherapy or limb perfusion chemotherapy, you'll get neurotoxic side effects. You'll get neuropathy, you'll get pain. If you radiate the nerves, they can have pain. If you constantly operate on a limb, you can get pain. So when we talk about quality of life after cancer, one of the things that I like to talk to my patients about is, would you do this if it meant your pain was reduced? And would you do it if it was not reduced? And if someone especially has metastases, they're not going to do it unless they know their pain can be reduced. And for me, the best thing I can do is give them quality of life and bring down their pain if it's not going to be curative. And if it is going to be curative, then I can set them up for hopefully a majority of their life pain-free. So that's where it becomes hugely important in my population.
Absolutely. And then some of the cases, some of the considerations, you know, do you offer the option of an amputation in a terminal, you know, diagnosis as a way of providing that pain relief, you know, and making those judgment calls?
I just did one in a woman who was widely metastatic, but her pain was in the leg. And an amputation can be a quality of life. And I think especially now when we know it doesn't have to be a lifelong commitment to chronic pain, that is actually what I'm most excited about by TMR. Yeah.
And that's exactly, I was going to say, the TMR just plays beautifully into this plan. We have so many wonderful comments coming in, and I do want to try to address every one of them. So Glenn says he's also an undifferentiated pleomorphic sarcoma in my sciatic nerve above the knee, left above knee, 2015. We got Chuck on board watching from the YouTube channel. So Michelle says that her son Joe had thought he had re-injured a sprained ankle, noticed the swelling in the calf, and inpatient chemo every other week. After 6 rounds, the tumor around the nerves and blood vessels didn't shrink enough, and they decided to amputate above the knee, followed by 6 more rounds with 2-month-long hospital stays for infection. Radiation for 6 weeks, and his motto, my leg or my life. So I had the chance to meet Joe, and he is one tough cookie, and he has a wonderful family who is so supportive there. Hey, Stephen, glad you could join in. So, guys, I do want to announce our Instagram winner is Donna. So, Donna, congratulations. You will be getting a very posh Yeti mug, coffee mug, and we'll be sending that out to you, and we'll contact you for your address for that. So, guys, I'm going to put out this last giveaway just because I want to give you guys time to do it while you listen to the really awesome part of this lecture. Here we go. All right, so I just posted the link to my YouTube channel to a specific video. Okay, in that video, it's one of my 2-minute chats, right? And it's a 2-minute chat on targeted muscle reinnervation. So highly encourage you to go watch that video. And yes, it's a shameless plug for my YouTube channel. So while you're there, please hit subscribe while you're there. Show me some love there. But the giveaway question is, what is the color of the blouse that I'm wearing in that video? So put the answer in the comment section, and my TMR team is going to be picking out a winner from there. But let's get back to TMR. Okay. So I'm going to give you guys the brief spiel on TMR. Those of you who've been watching the show you guys should know a lot of this information by now because we've talked a lot about it. TMR is targeted muscle reinnervation. Okay. So let's backtrack a little bit. In amputations, right? Techniques really haven't changed a whole lot in the past, 300 years. Amputations have been, y'all saw me at the Spanish military hospital, with their old-fashioned amputation equipment there, right? So basically, after the surgeon cuts through the necrotic tissue, the tissue that has to be cut through, one of those items is the nerve, right? So they will gently pull the nerve, cut it, and then let it retract back into the soft tissue. Okay. So as the nerve is back into that soft tissue, it starts to scar up, right? And it starts to form what's called a neuroma. Okay. If it happens to be on a sensory nerve, then we start seeing fireworks, right? A person will start to complain of either pain directly in their residual limb. They will start to complain of severe phantom limb pain. Okay. So this is another part that I always like to kind of my PSA for the show. The difference between phantom limb pain, phantom limb sensation, and residual limb pain. Okay. So phantom limb pain, and y'all chime in. This is like the after school special. Those of you who know the answers to all this, tell me the difference between phantom limb pain, sensation, and residual limb pain. So with phantom limb pain, the person is looking down and they feel pain in the foot that used to be there. The foot's no longer there, right? But they're feeling pain, crushing, burning, grinding, tearing pain, fire pain, very excruciating pain versus sensation. Okay. With the sensation, the person can feel their toes. They might even be able to wiggle their phantom toes, but there's no pain associated with it. And that is different from residual limb pain, where the pain is actually being felt in the limb that is still there. So why do I repeat this like a broken record on my show? Because it's important to understand the difference, because if you can do that, you can trace back the source of the pain and be able to treat it properly. Okay. If your pain is coming from a bone spur that is in your residual limb, you are not going to treat that the same way that you would treat a neuroma that is forming in your limb, right? All right. So let's get back on track with the neuromas. So with the targeted muscle reinnervation procedure, okay, we're giving that nerve ending something to do, right? So up until recently, and we still have a lot of this going on, if someone has a neuroma that's causing pain, that's causing fireworks, interfering with quality of life, and they decide to go in for surgery, right? Typically, all the surgeon was able to do would be to resect or carve out that neuroma. But then there's a big chance of that growing back in. Okay. So a wonderful surgeon named Dr. Gregory Dumanian and Dr. Kaiken about 20 years ago, they realized that if they took that nerve ending and plugged it back into a certain part of the muscle, they would give that nerve something to do and make that nerve happy, right? Idle hands make devil's work. So if that nerve is flip-flopping around in that soft tissue, it's going to cause trouble. You plug it back into the muscle, and all of a sudden it's happy. And we have had some amazing outcomes with pain relief. And that's where I'm going to let Dr. Roubaud take over, because she knows those stats a little bit better than I do. In terms of, if you can talk to us a little bit about the recovery process from targeted muscle reinnervation and how that works, the healing process works.
Yeah, so when you talk about all those different types of pain, that was a really great description. The statistics are hard to define, but we generally say that 50 to 75% of amputees will have stump pain without this procedure. Generally around 60 to 80% will have phantom pain, not sensation, pain. And what Damanian and Kaiken and others, Valerio's another,
Valerio, yeah.
is that you can drop that statistic down under 10%, which is hugely, hugely important. And in medicine, that's like an unheard of number. So that's really why this was sort of an earth-shattering discovery. The general process goes is that, for me in particular, it's a planned amputation. When you go in there and you cut the nerve, Valerio will describe it as grounding a live wire. I call it the buddy system because I have small kids. I give the nerve a buddy. And when you say you implant it in the muscle, you actually find a little motor nerve in the muscle. And so you have two nerves talking to each other, and that's why I call it the buddy system. And you actually sew the buddies together and they talk to each other. Now, because it's a nerve, the first 4 to 6 weeks, it's sort of radio silence, and patients will go through this sort of honeymoon period where they don't have a ton of pain except for the actual surgical incision. Mm-hmm. My anecdotal experience is around 6 to 8 weeks. The nerves start to wake up and they kind of do this electrical funny bone thing. Mm-hmm. And then somewhere around 8 to 10 weeks, my patients have been having their pain dramatically reduce. So it's sort of a honeymoon, a small peak, and then they stabilize. Mm-hmm. I've noticed that in patients that have this done multiple years after their amputation, they're a little slower with that peak and with the resolution, but they still resolve. It's just a little bit of a slower process.
Wonderful. And then see, Beth says, sorry, I'm getting a little feedback here. I was one of the first to have TMR with my left BK at Mass General, done by a neurosurgeon. I see a lot of folks considering TMR revision. In my opinion, TMR should be routinely discussed with the patient if it is elective, game changer for me. In my opinion, and this is my opinion, I think TMR should be for every single amputation. It's one of those, and when Dr. Dumanian was on the show, it's one of those that you're just sitting there going, why not? Mm-hmm. Right? If you've got that nerve, go ahead and plug it back into that motor point. Mm-hmm. And folks, I will, again, shamelessly plug my YouTube channel because we do have three wonderful shows on TMR with Dr. Dumanian, also with Joe Pleben, who came on the show and spoke to us about his personal experience with TMR. And he's just a wonderful story to listen to. And you can find all of this on the YouTube channel. And I think I froze. I don't know if y'all can still hear me. I'm here? Okay, so my screen. Awesome. We'll just keep going. Like I said, I have gremlins in my computer sometimes. So tell us a little bit about your work with TMR and your patients at MD Anderson.
Well, truthfully, I have a little bit of a unicorn practice. Cancer and sarcoma is a lot of what I do. I don't do any other kind. I just do cancer plastic surgery. And I started doing a lot of orthopedic surgery, and we were doing very high level amputations, meaning, hip disarticulations or hemipodectomies or 4/4. And it was great. I felt like we gave the patients a chance at life, but a lot of them had really bad pain. And I saw Dr. Dumanian speak at a conference I went to, and I pulled the classic. I just walked right up to him and I said, "You don't know me, but I have some questions." And he was the most kind, generous man. And he said, "Come to cadaver course. I'll teach you what I know, and you can take it back." And so for 3 years, I've been doing it at MD Anderson, and I've taught some of the other surgeons there. Truly, the credit should go to Dr. Valerie Lewis and Dr. Kayuri Popat and Dr. Hagen, who are a mixture of my anesthesia and orthopedic colleagues, because they really gave me the blessing to try this on their patients. And then the anesthesia team really supported me in those operations and helped me with the peri-op care. And then the rehab medicine team, which I'm so fortunate to have, they just swoop in day one and they just take over. And they're like, "Okay, we're done with you, surgeon. Like,
we're kind of bossy.
Yeah, you've done your little technical exercise. Like, let us fix things from here." And so we sort of have this multidisciplinary team, and what it does is it, wraps the patient in sort of a 360 degree of how we get over an amputation, and not only get over it, but thrive. and move on and have a great quality of life. And I think this has been most rewarding for me and my pediatric patients when, you know, these kids, I have kids, you have kids, these kids could be living for decades. Like, why wouldn't we set them up for the best life possible? So.
And for the best success. So thank you for that plug for the rehab team approach. Now here's a just kind of a weird question. Do you notice a difference in the healing process and the outcome from oncology related TMR versus non-oncology related TMR? Have there been any studies to show any difference there? Or?
Yeah, I think that one of the things, we have a bunch of data that's about to come out. One of the things is that my patients are unique and that a lot of patients come in with pain. So if you've had a ton of limb salvage or you've had a ton of neurotoxic treatment, you can come in pain. And so your brain is sort of keyed up already to pain. Mm-hmm. What I've been finding though is those patients, they still get relief and it still works. It just takes a little bit longer. And then I also find that a lot of my chemo patients, their nerves are a little sluggish. And so it takes me a little bit different technical skills to kind of get those nerves to fire and find what I need. But, you know, I think it's been a really incredible journey for 3 years. And I really think that everybody on the team is going to kind of seen it like, this is working. And all credit to the people who invented it. So.
Wonderful. And then for those of you out there who've been chiming in, and thank you guys again for sharing your stories. I love reading the stories. Which of those of you who are my sarcoma survivors, have any of you had TMR? Or are any of you possibly thinking about it? Is that something that are you living with pain, phantom limb pain? So I'm curious to see those statistics right there. Let's see. Mark S. asks, Doctor, is it common or unusual that I only get pain at night after I remove my leg, even though I wear a shrinker?
No, I really think nerves are really amazing. You can feel pain in a lot of different ways. You can feel pressure. You can feel temp. You can feel sensation like sharp or dull. And so a lot of times people will tell me when they offload their stump and they suddenly get swelling of the limb or they suddenly get a change in the pressure on the limb, that's what triggers their phantom pain. I also think they used to call it a diurnal flux of your cortisol and your hormones. It's how humans know to go to sleep. And I think that also plays with our stuff at night. So.
But Mark, it's not unusual. I hear, and usually, and I know you're a very active person, Mark, I hear that from my most active, those who wear the leg for 12, 14 hours a day, that they feel the pain. It's like the rebound pain, when they take the leg off at night. So I like to think it's just because they've been training their proprioception so nicely during the day that the brain just really accepts that as their leg. So when they take it off at night, the brain's like, wait a second, what just happened to my leg here? What just happened? Right? So let's see. Chuck says, when I had my amputation in April, I asked about TMR and the physician had no idea what I was talking about, trying to figure out if I should pursue TMR out of state because the pain now is unreal. So Chuck, I've had several people, like I said, email me. This is how I actually got connected to Checkpoint Surgical, which is the company that's in charge of TMR Nerve, because I had so many of you asking me about this, and I had to find a directory and I had to find out where are all these surgeons hiding, and there are lots of them out there, right? And the reason why I advocate for finding one of these surgeons is not just because you might need TMR, but maybe you don't need TMR. So remember what I said earlier about differentiating between what is truly causing your pain and doing an appropriate workup for that. That's where the value of someone like Dr. Roubaud comes into play, because she's going to know what a neuroma looks like. She's going to know how to test for it, how to find it, and how to determine if you're a good candidate for TMR. So as big of a fan as I am of TMR, if it's not necessarily going to address the pain you have, then, no need to put yourself through that surgery. Makes sense? Kind of master the obvious, but when you're in the middle of it, going through it at that moment, you're just thinking, I'll do anything to get pain relief, but doing it the right way. So Chuck, I'm going to put it out there and say, if this is a pain that is interfering with your quality of life, and having a consult visit, and who knows, maybe, and I'll just throw this out there as well, we have a lot of folks doing telehealth. So if you're out of state and you're not sure if you want to make that trip and you want to do the first consultation as a telehealth, find ask that surgeon's office. All right, so let's see. Asks, can the pain also incur in nerve? Oops. Harsh, I think you got a little typo there. You want to retype that? Oh, okay, sorry. Can the pain also incur in the nerve cut due to big toe amputation?
Mm-hmm. Yeah, absolutely. So there's another surgeon that does a similar technique, Paul Soderna, and he does a lot of work in fingers and toes and hands. And if you think about what a paper cut feels like, that's a small little digital nerve, and you've got 2 of those in your big toe alone. So any sensory nerve that gets crossed can absolutely get fired up, and you can treat it.
And then let's see. Susan says, love taking my leg off at night. It feels good. Beth says, mine feels like petrified wood without my leg on. So it's on until I climb into bed. Yeah, that means you've been very successful with your leg, Beth. So Susan says, I walked 1 kilometer my first time in 8 years since my TMR operation. Well, if that's not a resounding success, then don't know what is.
Yeah.
Okay, wonderful. So we have our winner for... Sorry, I'm looking at my cheat sheets here to see who our winner was for the YouTube challenge. And it's Diane Baker. So Diana, congratulations. We'll be reaching out to you so you can get your fancy Yeti coffee mug. And Dr. Roubaud, I'm gonna put TMR Nerve on the spot and say they got to send one out to Dr. Roubaud because they're really nice. So.
Thanks.
Not the time to ask, right?
Yeah,
so
I drink an obscene amount of coffee. So.
Cheers. Beth says, I had terrible phantom pain for years, but it has gradually subsided to perhaps 3 to 4 times yearly. And I can actually feel my nerve tightening and in spasm, and I can understand what a miracle TMR is. Yeah. And let's talk a little bit. Okay, so this is one of my favorite parts of TMR is the science. I call it the science fiction side of it, the Star Wars side of it, how they're using TMR for the myoelectric devices. And you've had a couple of patients, yes, that have gone on to use myoelectric devices. So tell us about them.
Yeah, I mean, it's incredible. I mean, I kind of describe it as the age-old bionic arm, but it basically, you use the TMR to create signals on the surface of the skin that a little microchip in a prosthetic can read. And it reads the little twitches on the muscle. And one of my prosthetists, he's had 2 of my patients, and he's just done a phenomenal job. And you can do up to 4 or 5 different muscle groups at a time, which then can be transmitted to basically the myoelectric arm or the electric arm. So it's a computer chip basically sending out the signals that your brain was trying to signal out. And it's incredible. Now, the thing is like all technology, if you remember the first iPhone, technology just keeps getting smaller and faster and better. And so I do think these myoelectrics are only going to get lighter and faster and more intuitive. But the technology is changing so fast, and the TMR is really pushing it. So, yeah.
And then eventually, the cool thing is all the technology from the upper eventually trickles down to technology for the lower extremities. So that's what's also fun. Comadre, compadre, thank you for joining us this evening, man. Good to see you guys. And again, with the use of TMR, I don't know if I have any upper extremities amputees listening in right now, but if you are, then you can appreciate, those of you especially who have shorter residual limbs, how difficult it is to use some of the more traditional mechanical prosthetic devices, right? So having TMR available to basically rewire the nerves that are left over to allow you to really be functional with the myoelectric prosthesis is just pretty amazing.
Absolutely.
So let's see. Beth asks, do most or all insurances allow TMR with the amputation or revision?
My experience thus far is that we have not had an issue getting it approved. Now, granted, I am at MD Anderson and I have a really powerful institution behind me. And they've been really supportive of this, but it has not been an issue as of yet. There is this, what we call in doctor language, a CPT code. So it's a 64905. There's an actual code that can be sent to the insurance and the billing. And so that is a real life code. And so it should be covered. But again, like all things in medicine, you have to ask your insurance first.
And And then Johnny V says, I've been living with neuropathic pain most of my 20-year survivorship as an amputee. Favorable outcome, and he is a sarcoma survivor. Of a TMR revision surgery to reduce discomfort for that length is the only thing I am waiting for. I maintain a very busy lifestyle to distract my pain, which provides me with improved quality of life. And Johnny, I know of a surgeon close by to you who's been on my show who does TMR. So we need to get you that number so you can just kind of ask those questions. Yeah. Johnny goes skiing. He's very active. So
Yeah.
So yes. So guys, with that, this was an awesome show. So I just want to say thank you to Dr. Roubaud for taking the time out of her very busy schedule to be with us this evening. Thank you to Checkpoint Surgical TMR Nerve for sponsoring the show and also for sponsoring these nice little giveaways right here. So congratulations to my winners. Folks, if I missed your question, I do go back and I check to see, which questions I missed. But don't be shy about tagging me or emailing me directly. I'll put my email on here, y'all. Probably should have it memorized by now, hopefully. Okay, so there's my email, guys. If there's any questions of yours that we missed or something that occurred to you later on, please feel free to send me this email, your question to the email, and I will get in touch with Dr. Roubaud and the TMR Nerve team to get you the answer. But guys, as always, thank you so much. And thank you to my survivors out there for coming this evening and for sharing your story with us and sharing, a little bit about yourselves and your journey. So thank you guys for letting us be a part of your lives this evening. We will see you guys next week, same bat time, same bat channel. And in the meantime, have a wonderful evening, guys. God bless.
Good night.